இல்ல நீங்க எதுவுமே கொடுக்க தேவையில்ல. நீங்க கொடுத்தாலும் இப்போ ஸ்டார்ட் ஸ்ட்ரீம் கொடுத்தீங்கன்னாவே போதும். ஏன்னா ஆட்டோமேட்டிக்கா நம்ம டைம் எல்லாம் வந்து செட் பண்ணிட்டோம். 1:30 கேட்டா வச்சிருக்கோம். ஓகேங்களா? ஆட்டோமேட்டிக்கா ஏன்னா நான் ஸ்ட்ரீமிங் செட்டிங்ஸ் செட் பண்ணி தான் வச்சிருக்கேன். நேற்று 1:30 வச்சிருக்கீங்க. சரிங்க. அதனால ஆட்டோமேட்டிக்கா அதுவா எடுத்துக்கணும். ஆனா கொடுக்கும்போது Good afternoon, everyone. KMCH College of Physiotherapy welcomes you all for this fourth day sessions of 10 days faculty development program. It is my pleasure to invite our respected speaker for today's first session, Professor Brahmata ma'am, to share her expertise on lower limb measures in physiotherapy research. Professor Brahmata ma'am, HOD Neurophysiotherapy, KMCH College of Physiotherapy, has been a guiding force in our neurophysiotherapy department. She has 24 years of academic and research and clinical experiences so far. At present, she is the Secretary Scientific Committee of KMCH Institute of Health Science and Research. She has received Best Academician Physio Award 2023 from SNS College. She has received grants and holding 9 publications so far. I welcome her to share her experiences now. Over to you, ma'am.
Yeah, thank you, my dear faculty. So, hope I'm audible. Am I?
Yes, ma'am. Yes, ma'am.
I'm audible, right?
Yes, ma'am. You are audible.
Okay, thank you. So, good afternoon, all. Thank you to, giving me this opportunity to present in our first FDP program from KMCH College of Physiotherapy. And this beautiful travel with you for the fourth day was an amazing experience. So, how you find the right path which leads to the right direction. Well-selected outcome measure will help to achieve our research goals or clinical goals. So, with that note, I would like to start my talk on outcome measures in physiotherapy research, especially lower limb mobility measures. So, to start with, I have a small Q&A as an ice-breaking session. Just those who are joined here, could you share your views about what is an outcome measure? Or why is it necessary? Just put it in the chat box, please. What is an outcome measure? Why is it necessary? Because that is our topic. So, what is our outcome measure? Just type it. Your thoughts about this question. What and why do you think these outcome measures are necessary? So yes, GP Sharon has commented to see the progression of patient, right? Very good. And then we have Mr. Pratik Prem Kumar, who has said to confirm the reliability and validity of an outcome. Maybe if you pick up the right measures, we need to pick up the right measure with good reliability and validity. Yes, Nerusai has commented to understand the progress of our treatment. And Dr. Nageshwari for quantifying and assessing. So all beautiful answers, very nice. So I think we are going on the right track. Prognosis of a condition, progression and validity. Yeah. Part one, an outcome measure is a tool. So for the first question, an outcome measure is a tool or instrument. So I think he has given the right answer to us to find out the effect of an intervention or training or exposure. So that is what. So what is an outcome measure? So the outcome measure is a tool or instrument or a method which we used clinically or in research to assess or to look for an effect of what we have done. So that's what is an outcome measure, and then followed by why do we want. So we, in different domains, different specialty, we use a lot of outcome measures. So most of you have given perfect answers. Yes, Mr. Edward, to rule out the condition and assessment and to check effectiveness of treatment. Okay, and yes, Nirmala Devi, the answer is prediction. So there are many outcome measures which help to predict also. So I think we are a group with good understanding of what is it and why is it necessary. So just to sum up what I told, so an outcome measure is the result of a test that is used to objectively determine the baseline function of a patient or individual at the beginning of the treatment or the course of the treatment, and the same could be used again to determine the progress and treatment efficacy. And obviously, it helps to provide a credible and reliable justification for evidence-based practice, and this should be convenient enough. So whenever you pick an outcome measure, it should be convenient to apply by the therapist. That is, the timing should be appropriate according to your setup, and it should be comfortable for the patient and tailored to the individual needs. So these are the things which you should keep in mind. So my talk will be on these areas. So my contents will be on the mobility, functional mobility, and ambulation. So now to start with, what is mobility? So mobility is like you do the simple basic functions. Like you want to be mobile, you need to have your strength, range, all those things to be mobile. So this continuum of mobility can change from like you're completely immobile or you're mobile in an acute setup or in a condition where there is more uh, deterioration. So those situations, the patient or individual could be completely mobile or immobile depending upon the stage, progression of the disease, so and so. So we do have lot of measures. The most commonly used motricity index and fugal mail for lower limb, and we do have our exercise therapy. I mean exercise measures like range of motion, strength, tightness. All those you can use to understand the patient's mobility level. And next comes to the functional mobility. So obviously mobility, if it is at the appropriate level, the patient could be functional enough. So functional mobility is the ability of the person to move around in this environment, including walking, standing up from chair, sitting down, I mean moving around the bed, and transfers, all those includes functional mobility. And ambulation is obviously the primary endpoint or the goal. Like the individual should be able to walk with or without a personal assistive device. So my talk and the measures which I have choose will be around these areas. So those will be my objectives. So the lower limb motor function, which is necessary to take the patient to the high functioning level. So the lower limb motor function refers to the ability of the muscles in the legs, hip, thigh, knee, ankle, and foot to generate controlled and coordinated movements, enabling activities such as standing, walking, stair climbing, and maintaining balance. So, in light of this, we do have the commonly used brainstem recovery stage for stroke. We have Chadok McMaster and Fugelman, which has been already discussed yesterday. And we do have stream stroke rehabilitation assessment of movement, and we have rubber beat. These are exclusively for stroke. And we can also assess the JPS, joint position sense test, or for sensations, we can go with Nottingham sensory profile and assessment, range of motion, and spasticity for the upper motor neuron lesions. You can go with modified Ashworth scale, modified Tardieu scale if it is a late spasticity interfering with tightness and all those, and spasm frequency scale for those who have movement disorders. So we have so many skills which we can utilize to understand the patient's lower limb motor function. Since some of the skills has been explained and the specialty people have used so much, this is of the common standard assessment tools. I have not elaborated all these in detail. So coming to the fugal mayor, which is very important for a stroke and so versatile and highly useful. So the proper fugal pair has got so many components. The total score is 226. It has got tests, that is domains, motor function, sensory function, balance, joint range of motion, and joint pain. So everything put together, you get a total score for 226 to understand the Motor recovery in patients with hemiplegia post-stroke. Now, for lower limb, you can pick up the subscale of lower limb and you can utilize that. So, the psychometric properties has been tested individually for all, and that's a 3-point ordinal scale, and you can complete it easily within 15 minutes. And the equipments required are a reflex hammer and a couch, which is easily available in our clinical setting. We don't require any fancy equipments. Next is motor set index, which is also equally used because it similar to your muscle testing. So it is the ordinal method. Uh, I mean, it is also having specific components for hip flexion, knee extension, and dorsiflexion. And test is done in sitting, which is also quite easy, and it has also for psychometric properties, and the equipments are very minimal only. So this is the test for the lower extremity motricity index. So I hope the screen is visible. The motricity index, we can see the leg scores, 3 components, and the scoring 0, no movement, 9, palpable contraction, 14, movement seen but not full range, and 25, movement is possible against resistance, but weaker than the other side, and 33 is normal power, so you the grade for each component, and the total score is calculated plus 1 for total 100, you get the score of the patients. This is another score to understand the recovery of the lower limb affected side. Now, next coming to the functional mobility tools. So the functional mobility tools, we have COVS or D Morton, elderly mobility scale, FIM, life skills assessment, river lead, and SPPV, short physical performance metric. So when coming into the functional mobility scales, we do have a generic version, like you have a fever, whatever may be the pathophysiology. The paracetamol is medication, right? Similarly, we have a generic outcome measure which can be used across all the population. Maybe it is TBA or stroke or Alzheimer's or geriatric. So this is one kind of functional mobility index, D Morton, or shortly called as DEMI, which could be used in a hospital setting or acute setting or IP geriatric setup. So it is versatile enough to be used. So the scenario, if you want to find the mobility level in your inpatient neuro-rehab setup, you can apply this for all the patients. I will show you the components involved. So there is a DEMI handbook available. So maybe you can read on that to get more information. So this is how the De Morgan Mobility Index page will look if you go into the handbook. So it has got many components from the easy component to the hardest. So it has got 15 tasks. I will show you the individual pictures. And there is a conversion score also available if you are using it for research purpose. So we have components like bridging, rolling onto the side, and then lying to sitting, chair, sitting, getting up from chair. So the simple mobility tasks. You can see components for static balance, and you can see components of walking and dynamic balance. So you have 15 items which you can test. So this will be ideal for a geriatric person in diabetic movement recovering, or somebody who is admitted in ICU. You want to see the overall general functional mobility, uh, geriatric population like Alzheimer's. So it's a kind of versatile. And next to DEMI, we have Rivermead Mobility Index for specifically acute stroke patients. So if you have a situation to determine the effect of supported sitting and standing on the functional ability in acute stroke patients, so they are very low functioning. So you can use the scale Rivermead Mobility Index. So this scale has got 15 items. This is the older one. So this assesses components for mobility, transfers, balance, and gait. It has got 15 items, and it is very simple. It is like 0 if you are not able to complete the task, and 1 if you are able to complete it. So 15 items, 15 score. Okay, if you are able to complete, 15 score. Got good psychometric properties, but the problem is the sensitivity with this. So they developed a modified version, modified Rivermead Mobility Index. What they did is here the scoring was split. So you have a score of 6-point ordinal scale, 0 unable, 1 assistance of 2, 2 assistance of 1, 3 with verbal cues or supervision, and 4 requires an 8, 5 independent. So the tasks here are like the same mobility task, turning, lying to sitting, sitting, balance, standing, transfers, walking, indoor stand. So all the necessary functional mobility items are available here. But the scoring has changed here now. So we have 5 into 10, 40 is the total score. Next scenario, you have a situation that you wanted to do a study to evaluate the effectiveness of motor relearning program on mobility following stroke on a particular group of subset of patients. So this in MRP you have a assessment tool, motor assessment scale, which is a performance-based scale, which you can use, which was given by Karen Shepherd. So this has got 8 items, 7 tasks. So one item is for tone. The patient performs the task 3 times and the best performance is recorded. So you can see here the movement assessment tool scoring sheet. So supine to sideline, supine to sitting, balance sitting, sitting to standing, walking, upper arm function, advanced act activities. And there are some specific instructional sets to score this. So which is also available freely on our stroke edge or on the stroke outcome measure database like Shirley and so everywhere it is freely available. Next is stream. So as I told you, stream is another performance measures to be used exclusively in stroke recovery to assess the coordination. That is when I explained about that motor function and which we want for the other higher ambulation, we want more coordination among the set of muscles. So coordination, functional mobility, range of motion, everything incorporated. It has got 30 items. So this will take 15 minutes. So it has got 3 domains: upper limb voluntary movement, lower limb voluntary movement, and basic mobility. The scoring is 0, 1, 2, like it's also like unable to do or partial support is required or full support is required. So that's how the various items are guided. So the first 6 items are done in supine, the next sitting, next with no support, then it's standing and then walking activity. So that's also has got good psychometric properties. And again for clinical use, a simplified stream is also available. So you can look into the reference. Now coming into the ambulation. So when it comes to ambulation, I would like to go further into the ambulation measures by anchoring on FAC as the primary outcome. Now if you have this FAC, FAC stands for Functional Ambulation Category. Now what is Functional Ambulation Category? We categorize the patient based on the amount of assistance they require for walking. So any neurological patient or even any orthopedic patients, anybody we can use. This is a generic versatile to use. So some patient who requires, as you can see in the first picture, who requires 2 people as assistance or we drag the patient, we give grade 0. And he requires moderate or maximal assistance, 1 person assistance, to minimal 1 person assist, you can give 1 and 2. That is some amount of assistance is required. Now 3 is he can require some supervision or with some assistive devices he can walk. That is 3. 4 and 5 are independent. So, but the difference is 4, the person is able to walk on level surface only. 5 is uneven surface and all the stair climbing. So this is what the categorization of the FAC. So this is a categorical scale which helps you to understand how we can combine this with other, because it gives you an idea about the patient is a low functioning patient or a high functioning patient. Then we can add on the necessary outcome measures. So when it comes to walking, we have to see the 2 important aspects. The first one is ability to walk. The second one is how they walk. So the first one, ability to walk. From the FAC, we know that how much assistance they require. So the 1, 2, 3, they require some assistance. 4 and 5, they are independent. So that is the ability to walk. When coming to how they walk, you need to understand the quality of walking. So there are many indicators which you can study if you want to know how they work. So now our biomechanics will come inside. So if you see the biomechanics, we have a lot of temporal variables, spatial variables, kinematic variables, kinetic variables. So we can try to understand and pick up any of these variables with the available measures. One commonly used is like somebody who is coming to 4 and 5. It's ideal to use because that is a recommendation from the modified FAC. The 10-meter walk test could be used to identify the speed because they walk on level surface, they walk on slopes or uneven surface. The speed could be documented, especially like PD it is necessary and a patient, stroke patient or head injury who has recovered, head injury RLA 7, 8, 9, ideally it is necessary. So 10-meter walk test, yesterday's talk we had an elaborate information about that, and if not, you can go with 2-minute walk test for the endurance or 6-minute walk test for aerobic capacity. So because walking, you need to walk without fatigue and you need to have good sufficient amount of functional capacity. So this is something which you can combine with somebody is able to walk and is at 4 and 5 level. Now, if you have a situation like you want to find the effect of body weight supported treadmill training on the gait parameters. Now, I am using FAC. So, if I am using FAC, what happens is the patient is able to walk. He has, after the training, is he able to walk? He'll be still in the, he'll be able to achieve 4 or 5, he'll be independent in walking. But the FAC doesn't give you more idea about the what is the next level of recovery or improvement. So that is called as ceiling effect. So ceiling effect occurs when the participants in a study or assessment consistently score near the highest possible score. Now, FAC, everybody is reaching 4 and 5, or you have a score that everybody is reaching the highest score in that. That is called a ceiling effect. So we have not picked up the appropriate tool. So it limits the ability to differentiate between the individuals like who are in process of recovering or between the groups. So that means what? Maybe the test is too easy, or it is an inappropriate measure, or it is not sensitive enough to pick up the recovery, or they have reached maximum recovery. So we need to go to the next level of outcome measure or assessment. So we go to the next level of gait analysis. So what is gait analysis? It is a systematic way of doing the assessment to identify the various variables which I mentioned you. So suppose if we have the gait trainers and you have the machines giving you the output, fine, well and good, and you have separately instrumented gait analysis. So this gait analysis now we can divide into that is observational gait analysis. Next one is instrumented gait analysis, because everybody is not going to have the instruments. So we have the conventional observational gait analysis, we have the instrumented gait analysis, and we have the wearable technology also helping for gait analysis when you go into the real life settings. So this is how the gait analysis could be perceived. Now we have the observational gait analysis and riverbed visual gait assessment, which has all the components which is required for gait. And to standardize the observations, we have the observational gait analysis like DGI, figure of gait, certain components, and we have FGA, functional gait assessment, DDT, Wisconsin, which I'll be elaborating. And the instrumented gait assessment can give you a complete graphical or a pictorial representation of the various variables like cadence, leg cycle time, single leg support time, stance space, symmetry, step length, stride length, support duration, sway, velocity, symmetry, everything, whatnot, everything it will be given by you. Now we have the wearable technologies using gyroscopes, accelerometers for the specific kinematic measurements, and foot switches for kinetic measurements for the post output. So coming into the dynamic gait index. So this was developed as a clinical tool to assess the gait, balance, and solve. So somebody said prediction. So prediction scale is used. So it evaluates not only the usual steady state walking, but also walking during more challenging tasks. So you need to have particular distance 20 feet and it can be performed with or without the assistive device, but that has to be documented. So this DGI has got 8 facets of gait, and like 8 components you will be assessing, like gait with on level surface, gait in changing the speed of gait, gait in horizontal head turn, vertical head turn, pivoting, step over obstacles, around obstacles, steps, everything. I'm sure next speaker is also going to add more information about that. It's a 4-point ordinal scale. So you have got 8 components, 8 items to assess, and 4 points. So somebody who is doing well will get the maximum 4. So you get the maximum score here, which is the highest functional ability. Sorry, 3. So you have got 8 components, and your scoring will be 0 to 3. So 3 into 8, you get the maximum score, that is 24. So somebody who is less than 19 this are risk of mode fall. So this DGI, I'm sure it is not visible to you for most of you, but these are the components which I explained you. Now the FGA, Functional Gait Assessment, is the next version of DGI. So what happens here is they have added a few components, that is walking with narrow base, eyes closed, and ambulating backwards. The assessment, it is again an ordinal scale. 0 to 3 will be the assessment. But I told you the number of test items have been added here. So what happens? The score a little bit will change. They have made it little bit sensitive compared to the dynamic gait index. So they have added up some more components. So that is about functional gait assessment. So you can see here gait level surface, changing in gait speed, and they have given some specifications. They have standardized by giving some specifications for what is 0, what is 1, what is 2, what is 3. So the total score is 30. So 30 means he is a high functioning patient able to walk with full maximum capacity. 0 is severe impairment. Now next situation is you want to recognize the risk of recurrent falls in community with Elling elderly scale. So now you want to pick up another scale which should be better. So GARS, gait abnormality rating scale, is another one which is also having good psychometric properties. So particularly in older people, and also it is used with other neurological impairments. So developed by Woodson and colleagues, it has got 16 items now compared to the previous. You can see more items. It is not that you should pick up a scale with more items. It depends on your objective. So now this GARS has got 16 items, and the items are like you have items on variability, that is how the patient's stepping patterns are. So is it how much variability is there? Guardedness while walking, weaving, that is irregular patterns, and staggering, waddling during walking, and there are much more like there are components for lower limb. Also, the interesting part of this long version of GARS is it has got component for HAT, that is head, arm, trunk. So we know that while walking, we require the head, arm, and trunk movement biomechanically. So we do have some categories for elbow extension, shoulder extension, and all the upper trunk flexion forward. So we want to assess the gait considering the person as a whole. GARS also could be thought of. The total score is 48. And sometimes if you find it too long, you have a shorter version with the 7 items. So that also could be used. Now, coming to the next scale, the effect of, if you want to work on a situation like you want to find out the effect of home exercise program for improving gait in individuals with chronic stroke. So we have another observational tool, which is called as Wisconsin Gait Scale for evaluation of the gait quality, especially in individuals after stroke with hemiplegia. This has got 4 subscales and it accesses the 14 spatio-temporal and kinematic parameters, like your consecutive gait phases. But this is kind of reverse. So 1 is normal, 3 is atypical. So this assesses the gait, and that means what? If the patient is scoring the full score, 42, that is having performing very bad in his gait assessment. So this is the scale component. It's also available freely. So next, moving on to the much more quantifiable gait analysis tools. So if you want to quantify your gait analysis, uh, we have laboratory or instrumental systems, and we have non-wearable sensors and wearable sensors, which you can use EMG if you want to find out the muscle activity. Specific, if you want to focus, your research is highly focused, or clinically you want to find out a particular problem, then we can go with EMG analysis, or maybe you have other patients where you want to work on the metabolic costs. Uh, we can go with the instrument, but the problem is this is a lab oriented, and we do have portable forms also, but depends on the feasibility of it. Now coming to the sensors which pick up the activity which we want. So the sensors, we have 2 categories. One is non-wearable, that is your cameras, infrared sensors, optokinetic systems, everything. Non-wearable sensors. So you need to have an entire room properly set and calibrated. We do have, this is the first one is for the kinematic variables to pick up the ranges and the body postures and kinematics. And if you want to pick up the force GRF and the force kinetics, you need to have a gate mat with flow sensors. The more the flow sensors and calibration, you get a good pickup. So force platforms, these are all used. Again, you need to do it in a proper lab setting. And if you want to go to the real life scenario, you can take the use of the wearable sensors. So we have wearable sensors, accelerometers, gyroscope sensors, active markers, and all those six portable forms, which we can use depending upon our need and the necessary for the patient. Now, what are the pros and cons of the non-wearable sensors and the wearable sensors? Now, if you see, as I told you, the non-wearable sensors, your gait labs and gait assessment, they give more accurate analysis and you can evaluate the plantar pressures and all those things. But the problem is you need to have operational space. So real time is not going to be available. Maybe you get continuous monitoring, but how this going to translate into the real life carryover effect, that should be done separately. Now coming to the wearable sensor, it is very smart, easy to use, low cost. You can get 24-hour recording. Maybe especially for adherence studies and all, you can use the pedometers which we have in our phone. That is a very good way to utilize. But the problem is they are less accurate and you need to standardize the applications to get the correct result. Now, if you see again, the gist of this is the cost is too much and you need more space, but it is highly quantifiable and recommended. Some measures are gold standards. But if you see the wearable sensors, though the cost is low and the space is less, but there is something called as drift effect. Now, what is drift effect? That is, we need to place the sensors because if you want to place the sensors, you have to follow the guidelines and you have to standardize the procedure and calibrate it properly. And you can, in some situations, you need to even validate also. So if you want to do that, if you do that properly, you can reduce the drift effect. So that is, if you especially measuring the kinematic variables, the movement and the placement, if it is not right, you'll be getting a lot of drifting effect. Now, these IMOs, we are speaking more about the IMOs here. So all these IMOs, that is inertial measurement unit, uh, they are used for human activity recognition. They are electronic devices that measure your body specific force, angular rate, uh, separately or in combination with like accelerometers, gyroscopes, some smartphones you have got, some PlayStations. So likewise, you can combine and we can use it for assessment as well as for therapy. So we have triaxial IMU sensors or even multi-axial IMU sensors are also utilized. Maybe para Olympics, if you want to train, those things are also utilized. So that's it. So these machines they have a pre-structured normative values. So when you get an output, that will be compared with the normative standardized values, and you get an output like we get our lab reports. Now, so many things out there. Now, where it should be used and for what it should be used. So that is the slide here. So the wearable sensors, especially accelerometers, offer more accurate information about kinematic and spatiotemporal variables and especially PD population because to target their specific focus problems on to correct the decreased step length or gait velocity issues. As well as accelerometer is it has got best in predicting alterations in cadence, gait speed, step length in those affected by cerebral ataxia. Non-wearable devices such as instrumented gait labs pressure mat are useful to measure the kinematic GRFs, like where they have asymmetry in the weight bearing, plantar pressure distributions, sway problems, especially when you're working on the dynamic balance and sway. So those things, they are good. Even in fact, in TBI patients also, center of pressure, that is if you want to see more about the sway, alterations and balance and postural control, force plates and pressure sensors are best to pick up. Now coming to the community walking, that is finally the patient has to get back to the community. So community walking, the speed is very important. So you have a single task tool or you have multiple task tool. So single task tool, you can have a step test, or a side step test, post back step test, figures, and much more. I've just mentioned few. So there are a lot of tests which mimic the real life situations, and you can take into these tests into dual tasks. Like say, for example, you are doing a figure of eight walk test. You can do a simple figure of eight walk test, or you can do a dual task figure of eight walk test. That is a motor. You can ask the patient to carry a tray with one glass of water, tray with, because that is what real life happens. You carry your tray with four cups of coffee and you go to the hall. So that way, or you talk. That is cognitive dual task. So you talk by carrying it with the motor activity. The straight line also you can do. You can do a time 10 meter also dual task. So that's how you can proceed if you are working on a higher functioning patients. And you can have tools which have multiple components. A few we have seen because balance is essential for gait. The balance components yesterday we have seen, but for those who are missed up, we have work balance scale simple. We have best. We have Runnel. We have and your community balance mobility scale. We have every functional ambulation. These all to be added up with our gait measures. Now, as we know that it is not only for assessing, testing, prognosis, but these outcome measures are used for prediction also. So now the AI, we have various ways for gait estimations and algorithms. It is very clumsy, right? To fix a lot of sensors and everything. Even if you have a handbag to while you're just going for a casual shopping, it is a mess for us. So if you have so many sensors and you train and you work really mess for the patient. So what nowadays the AI is doing is you give one parameter estimated, it gives the remaining parameters. So those forms of AI and prediction algorithms are available. One such prediction algorithm is twist for volume. That is, if you have so many measures, so this picks up certain values and input, and it gives you an idea about how much prediction is possible for a post-stroke person. Like similarly, for other population also it is available, but mostly we work on stroke. So I'm just telling you this. So if you know the input of the trunk control test values, and whether it is more than 40 or less than 40, and the FAC values and the MRC values, you can predict the patient's ability to walk by 12 weeks. Again, this validity has to be tested for each subset. That's very, very important because even though it's a bedside assessment tool for predicting the time to walk independently after stroke. But this predicts the patient's ability after 6 weeks, 8 weeks, and 12 weeks. But this has to be tested and validated for each individual population. Like I mean to say, ACS stroke, MCS stroke. So that validation is very important for the subgroups. So the next scenario is a traumatic brain injury patient. So this traumatic brain injury patient who is in RLA 8 or 9, high functioning. So we have a tool called as HIMAT. This is a great assessment for completely higher functioning patients. So I'm not elaborating into that. It has got 13 standardized items, especially for TBI patients. Just wanted to show you this. Now you have another situation like you wanted to work on an incomplete spinal cord injury patient. Robotic assisted gait training is going on the loco band. So what are the choices you have? So you can use the FAC as I told you, but apart from generic measures, you have condition-specific outcome measures like walking index for spinal cord injury version 2 and lower extremity motor score and ski 5. So these are the outcome measures. They are available in the this Skyr project website and SRA lab also they are available. So you can see here how the walking index for spinal cord injury, just grading the patient based on his ability to walk. So this is how the scoring happens. You can see the various levels, the 20 levels, they are scored to assess the patient's progression and recovery. Now, another example to evaluate the effectiveness of hippotherapy on gait and diabetic CP. We all know hippotherapy, the equine therapy on the horse, will help to reduce the spasticity, improve the gait. And now with the upcoming horse riding centers, even one of my patients asked, can we go for that? So, what will be the choices? Like we wanted, because he is a walking child, we wanted the temporospatial variables, pelvic and hip kinetics to be assessed because that is what we want to improve. So you can go with some advanced, like you can go with three-dimensional motion analysis pre-post. And they have a standard gross motor function classification system. So you want to improve the person's functional level to the next working category. Then you can take the subcomponent of the GMFM and definitely spasticity measures you can add up here to make your assessment complete. The next scenario, you have a multiple sclerosis patient. You want to give a virtual reality based treadmill training. Now you can, apart from your generic measures, anything like your walking endurance test, 6-minute walk test, timed up and go test, FAC, everything. But if the patient is doing well, walking independently, you can add up the single and dual task condition. That is what very important. Obstacle negotiation for an ataxia component if it is more. And multiple sclerosis walking scale is something standardized for specifically for MS and obviously EDSS. These are the ideal choices. And though it helps for prediction also. Now this is the question for the participants today. So which patient is there? So with that, my talk is going to over. So what patient, what condition? Yes.
Muscular dystrophy.
Yeah, muscular dystrophy. What is the therapy going on? So it's time to activate our brain now. Yes. Muscular dystrophy, go over sign, fine. So now what is the therapy going on?
Virtual reality.
Yes, yes, right. Thank you. So it is a home-based therapy because we can't have the DMD child uh, to come to a department on daily basis. So we have a home telephysio, and if they have the feasibility, the home-based virtual reality training, or they can have the VR devices. We have a situation where you can want to assess do a big assessment. After assessment, the patient is participating. So what could be the ideal outcome measures? Yeah, maybe therapy is not reliable. uh, we don't say that therapy is reliable. Outcome measures only we look into the reliability and validity. Therapy, we have to look into the feasibility, adherence, those things. So what do you think? We have seen a lot of generic measures also today. So what do you think you can add up here for balance or walking? Have a holistic or a home-based multimodal therapy program going on to maintain his ambulation as long as possible. Just type it. Come on, guys. Don't worry. Can we use FAC for you? Functional ambulation category? Yes, definitely. Because it gives you, because we know at the median age of 12 years, most of the DFD child will become dependent for ambulation. So obviously, FAC could be one choice. Apart from that, you want to look into specific any components. We want him to work. That's all. We don't want him to be very pakka in his parameters. Synergy is something we don't think of. What about the timed up and go or work balance? Pediatric work balance scale is there. Give me some inputs. They're all. So generic, we can go with FAC or even your simple maintenance exercise. Only we can go along. No, I'm not asking about the therapy. I'm asking about what out. See, now you have a patient, you just come for a review. So you wanted to give a prescribe some set of exercise. So this is just one. There may be a kind of a multimodal exercise incorporating all the components for him. and this child is going to come after 3 months or 6 months for review. So he is ambulating as of now. Our goal is to maintain the ambulation but not deteriorate for a DMD. So what outcome measures we will have to see his progression? That's what now the discussion. So not the therapy, it is about the outcome measure. Yeah, dynamic gait index you can do, but that will end up in pediatric balance scores and even impact time 10-meter walk test. And his Arabic capacity is very important. So 6-minute walk test or 2-minute walk test because you have to keep track of his fatigue level and Arabic capacity. So your choice could be revolving around this, and obviously range of motion because his range of motion, muscle power, uh, and there is something called as there is a condition specific scales also we can think. So we have I think for a DMD big nose lower limb scale as well as we have for, especially for ambulation North Star ambulatory assessment for DMD children. So these all could be your choices. So that is for a pediatric population. So with that, I'm coming to the end of my session. So the summary is we have seen about the mobility, functional mobility, and ambulation, and we have seen about the fugal mayor, river weed, demi, uh, some other mobility measures, and the routine exercise assessment could be incorporated. Apart from that, we have standardized measures which has been recommended by the core set of guidelines from the stroke compodium as well as the APTA guidelines, EuroPD guidelines, and we have the stroke handbook 2020. So Shirley ran. So these are the references where you can find all these outcome measures. For spinal cord injury, we have a separate website, and Skyr project will give you more information. And there are a lot of landmark trials which also gives you an idea about the various outcome measures. Like if you go into the LEAPS trial, you will get entire information about the lower limb outcome measures, Fiddle Mayer and all those things, LEAPS trial. So these landmark trials will give you much more idea. And since there is more heterogeneity in the neurological population, we need to be very specific what we want to choose. You have to choose a scale which doesn't have a ceiling effect and a floor effect because we don't want to choose a scale which is too easy for the patient or it is too complex for the patient. So I said already, ceiling effect is if you use a scale and more patients are getting the top score, maximum score, all the patients are getting full score. That means what that scale is having ceiling effect, but for us it is not necessary to do it and find out. We have all the standardized information. You go to the Shirley lab measures, they have given all the points there. What is the psychometric property? What is the ceiling effect? Whether this scale has a ceiling effect? Whether this is sensitive enough for this particular population? All the information are given there. So when you choose a scale, please be very clear with that. And since real life is highly unstructured and variable, we are using a lot of technological advancements like sensors, tools to do the monitoring in the real life. So we discussed about a lot of kinematic and kinetic variables. So that's the summary of my today's talk. So thank you everybody. Thank you for giving me this opportunity.
Thank you, ma'am, for your insightful, inspire brainstorming session. Thank you, ma'am.
Dear participants, if you have any questions, you can ask or put in the chat box. You can take up your questions now.
Ma'am, in some cases we can use gauge scale for acute stage, ma'am, without any variables.
Acute stage.
Yes, ma'am. Without suppose we don't have variables, what we can do?
Variables are not mandatory and not necessary. Somebody who is really interested, then only we have to go about that. Variables is not a mandatory; it is just a choice. So if you are acute patient, I said no, we have to first. He is a low functioning patient, so we have to look into the mobility aspect. So you can use the mobility scales.
Okay, ma'am. So what scales we can use, ma'am? Which scales are reliable? But I'm trying to do a descriptive study about lower limb assessment scales, ma'am.
Yeah, that's what at the beginning of the first few slides I have shown you. That is,
Yeah.
if it is, what's the population, stroke or what?
Ma'am, only if the population stroke population case also. In some cases, I am choosing neurological conditions like multiple sclerosis, some cases.
If it is that's what I gave you an example. So just rolling my slides for that. So if you have a mixed population, Delhi is there. D Morton mobility
Okay.
index.
Mhm.
Rivermead is there. Yeah.
Okay. What are the scales other it's available, ma'am? Can I show them as reliable?
Yeah, all the scales psychometric, they are all having good psychometric properties. Those scales only I mentioned here. But so you wanted in an acute setup, right? Acute setup.
Yes, so in acute setup.
So if you're having a patient in your ICU or in inpatient setting, these scales will do good. Your DEMI or Rivermead, if you want to work only on the tasks alone, even if your MAS also will do well.
Ma'am, we can, in that conditions we can measure proper synergy or we miss something, ma'am. During assessment.
Synergy means we discussed synergy in the only with respect to stroke, because we have that synergy and the expected recovery pattern in stroke. So if you want to go according to the synergy, Fugelmate is the best choice. And we do have, if you don't want that hierarchical nature given by the set of components which comes in the order, you can go with motricity index because the core set of muscles are assessed there. So you can go that way. But you said the mixed population, right? So mixed population means you have to take a generic mobility measure. Yeah.
I have another doubt. Why I ask this because while rehabilitation, we can't make patient to walk with proper synergy. So we can't get probability of 70% for recovery.
That's what if they are not able to walk. So you have a component. So now if you see in this scale, somebody who is not able to walk, this is like able to do means one, not able to do zero. So you have to pick up a scale like that when you can't have a scale with lot of scoring components. You have to pick up a scale like this for a low function. Yeah. So yeah.
Can I take Demi and Filmmaker, ma'am, for liability?
But again, see, you said a mixed population. If mixed population, I know what kind of population is it. If it is plasticity and a recovery pattern, your Filmmaker will go do well. You can understand the recovery there. But you have a geriatric patient, post-diabetic patient, means the synergy will not apply there.
Okay.
So you should go with a generic scale like this. If they are not able to do these components, you can score 0. No need to test that. Simple to complex. Yeah. So the scoring itself is there. 0 means not able to do. When they're able to do, you will you observe that, you score 1. That's all.
Okay. Can you these scales? Did you mention in that scale? Can I use that, ma'am, with your permission?
Yeah. These are all free scales available for research purpose. If you just go and Google it also, you will get it. I told you, right, there is a DEMI handbook. You just go and type DEMI handbook. You can get the entire set, procedures, everything.
Because in some cases, they are not accepting the scale for research purpose.
If
they are denying because they are talking about synergy. That's why I'm asking.
Synergy is applicable only for stroke. Only we have a recovery synergy. Now, if you see now this scale, Rivermead mobility index, it is applicable for any neurological population, stroke, head injury. Synergy, not need to confuse with synergy. So, in the low functioning patient, we just want the mobility change. That's all.
We can use we can also include brainstorm also for recovery approach.
Brainstorm recovery is only for post-stroke recovery.
Okay.
And if you want, you can mail to the developers and get the permission. But even though it is free to use, some places they will ask because it depends upon the university where you are working for a research. So if they demand that, you can mail and get the permission letter. They will provide you.
Okay. Thank you. Thank you so much for helping.
Yeah.
Thank you.
Yeah. North Star ambulatory scale is available especially exclusively for DMD. Just go and type it in there is a website exclusively for DMD outcome measures. You will get it from there. Yeah, infant motor performance according to the age, like you want to work on CP or it is a high risk neonatal infant or it's a Down syndrome. We have condition specific scales and we have for their developmental levels we have specific scales. So the simple to use from PT side is GMFM. But as they cross the age 1 year, 2 year, we have some age specific scales for them. Vigno scale, DMD. Okay, anything else? Shall we close this session? Somebody
Thank you,
raised
ma'am,
his
for
hand.
that.
Yeah.
Ma'am, we can. How many samples can we take for this? Another doubt.
See, it depends upon your objective. Now, the same example which you told me, if you want to pick up a sample, for each scale they have given the like you want to be in a proper research way. If you want to calculate the sample size, you need to know the effect size of the effect size or the MCD or MCID of the each outcome measure we are using. With you can incorporate
Okay,
that
detection.
in your you can use that and incorporate into your calculation and you can derive the sample size so that your power is sufficient to do the research.
Ma'am, may I know about MCID abbreviation, ma'am? I didn't remember.
We for each scales, what we have is we have something called as MDC. MDC means minimal deductible change. We have MCID, that is minimally clinically important difference. Now, what is the difference? Is MDC is something which we focus for statistical significance of the change. Now, the MCID, that is minimally clinically important difference, focuses on clinical relevance. Now, if you are using a PR on patient related outcome measure or your therapy is more of patient oriented, you can look into the MCID. That means what? If you find a change, G scale has got a MCID. Say, for example, your feeble mare lower limb. Chronic CVA has got 6 as MCID. For acute, you don't have proper MCID. But for chronic stroke, if you are after 6 months, if you are working with some intervention, if you are using FEMA and if you are getting 6 points change, that is a minimally clinically important difference. That difference would really be meaningful for the patient. Got it?
Yes, ma'am.
Yeah. So for each case,
Yes,
you can get that. Yeah, thank you. So I
Mm.
think it is 3 o'clock.
Yeah, ma'am.
We can move on to next session. Thank you, everybody.
Ma'am, after sessions, if I any doubt, can I call you, ma'am, for that?
Sure. You can call me or maybe you can text me also. I will give you the necessary information.
Yes, ma'am. Thank you.
We are doing this FDP to share the information and we want very good research in our professions. That is what our idea. Thank you so much.
Ma'am,
Yeah.
one thing, don't mistake me. I'm a UG candidate, ma'am. I'm in my
No problem. No problem. No learning. Those who are interested in learning, definitely learning is the primary criteria. That's all.
Okay, ma'am. Thank you. Thank you for it.
Yeah. So please move on to the next session, please.
Okay. Now for the second session, I am honored to invite Ms. Janani ma'am, Masters in Neurology. She has 4 years experience in academics and research. She is having few publications and conference proceedings. She will deliver a talk on assessment movement disorder. We welcome you, ma'am. The floor is yours.
A very good evening to one and all present here. Thank you for the invite, sir.
Thank you.
I'm Janani SS. Am I audible?
Yes, ma'am, audible.
Am I audible? Fine.
Thank you.
So, With a great and immense pleasure, I welcome you all to the session 2 of day 4, following a fantabulous presentation by Pramadama. It's a much honor to present on this platform and before you. On that note, I would like to thank the chairpersons of our institution, the principal sir of the college, vice principal ma'am of the college, and delegate members of the organizing team, and my dear colleagues. Saying that, we go to the presentation. So today we're going to talk about in the session 2 on movement disorders assessment. Looking on to the objectives, we will be having a very short, please don't worry, because looking on the anatomy and physiology, you might be worried that it might be a regular lecture class, of course, but not so much in depth. Let's just have a glimpse on the basic anatomical and physiological things happening beyond the movement disorders. And we're going to explore the types of movement disorders very quickly. And since we have a plenty list of movement disorders, I would like to narrow it down to a scope where we explore more clinically. So I'm going to specify a condition, and based on that, ICF modeling will be projected, and based on that model and all those categories, we're going to build on outcome measures and look into the psychometric properties, just going to have a glimpse on the current update on every outcome measure. So probably my screen is visible. This is what we used to perceive if I say brain. And coming to the movement, especially the motor component, we all think that, of course, we people are well rooted in neuroanatomy and physiology. 90%, if we talk about movement or motor component, the thing strikes in our mind will be cerebrum. That is, especially in order to delineate, especially the premotor cortex, supplementary motor cortex, or prefrontal cortex in that way. So even though it is looking big, it's not only the cerebrum is not only looking big, but it is occupying a majority of the perceivement in our mind that it is essential component for the it's not a myth, it's already been proven one. But along with this cerebrum, actually, it's having a very fancy design. Being a big one, it is occupying that much. But we are having a major contributions which has been provided by all those, we call it as subcortical structures. Those are the scattered gray matters
Ma'am, sorry, ma'am.
deep inside the cerebral cortex.
Ma'am.
Yes, sir.
Ma'am, your screen, please could you touch hide, ma'am?
Sorry?
Ma'am, new presentation.
Yeah.
Below, give stop sharing and hide, ma'am. Please give the hide option. Hide.
Oh, give the hide option. Fine. Yeah, thank you for the information. I think it's fine now. So yes, most of the subcortical structures plays a very important role, because if we take a moment on the whole, the generalized idea was generated, not even generated. It has been conceptualized by the cerebral cortex. But all those detailing or specification of movement will be contributed only by these things, what we can see, tiny things inside the cerebral cortex. Say, for example, we can see the thalamus, basal ganglia, cerebellum, brainstem, and everything. Here, we just follow the course which is coming from the cerebral cortex. Just look at the arrow present onto your left hand side. You can see there is an arrow just going to the basal ganglia. You can also see an arrow mark reaching the cerebellum. I would like you to focus on the basal ganglia thing. You can see the arrow reaching from cortex to the basal ganglia, and from there it is going to the thalamus, and again it is going back to the cortex. So it is kind of loop, right? It's kind of cyclic thing happening over there. So we call this as a motor. So apart from this, we will be having our limbic system along with it, so it completes the motor loop. So you can see those good lines like initiation, selection of motor programs. Yes, here where the basal ganglia is having a major role, even though the cortex is decided to start a volitional movement, basal ganglia is a structure which initiates, like how much amount of force is to be needed to initiate the movement, how it has to be sustained, how the agonist and antagonistic contraction velocity or balance has to happen. Everything will be guided by the basis of the basal ganglia. And there are many things over here. Considering the time, I'm not just looking onto all those things. And you can see this right hand side arrow marks where you can see the typical descending pathway what we can sense. We have Typically, we used to sense in this way, right? Cortex, it goes to brainstem, and via other extrafrontal tract system like reticulospinal, vestibulospinal, spinal reaches the spinal cord. There's anterior portion of the spinal cord reaching to the effector organ, so the movement happens. So before all this typical pathway, this much amount of fine tuning is happening under the cortex, so we call it as a subcortical process. So I would like to highlight this thalamus as a relay station as well. So coming to the hierarchical, let me be very quick over this. We all know that the supreme hierarchies are like cerebral cortex, which initiates voluntary movement, and the thing will be relayed down to the brainstem, which will be more focusing on postural tone and rhythmic movements, which has to be elicited. And finally, deep down, it will be coming through the spinal cord, where it can produce only reflex kind of activations. So anywhere, any lesion happening on this hierarchy, the other center will be taking the call on. Coming to the subcortical system, as I had mentioned upon that looping diagram, basal ganglia. Let me go to the anatomy first. So coming to the anatomy, basal ganglia, basal is nothing but the subcortical deep inside. Ganglia is nothing but the group of neuronal cell bodies we used to have it. So we are having primarily the caudate, the putamen, the globus pallidum. Then we are having the subthalamic nuclei, and we are having the substantia nigra. Anatomically, we can consider only the caudate nucleus, putamen, and globus pallidus alone as basal ganglia. But functionally, we will be having or extending the hands to the subthalamic nuclei, which is a subthalamus on its own, and also extending to the substantia nigra, which we all very well know that it's a part of a midbrain. So functionally, the subthalamus and substantia nigra also sits inside this motor tape. So yes, this constitutes one among the extrapyramidal system. And it is concerned with the movement initiation and also the cognitive aspect of the movement. This is very important because movement is not only a pure kind of motor loop, it does have the inputs from every of the sensations like primary sensory systems for the movement will contributing like visual system, vestibular system, tactile system, along with the stored memory present inside a post-central gyrus, which is the primary sensory area. And cerebellum, of course, we are not talking much here, but it is also having a role on error correcting mechanism, and it is having a kind of forward loop thing that we have everything in proactive. This is about basal ganglia. And on to the next slide. I just want you all to be a little careful for the upcoming 3 to 4 minutes because I think you remember this slide. Please check here. This slide, I mentioned about cortex, basal ganglia, thalamus, right? The small triangle. This entire triangle, we're going to divide it into two pathways. That is direct pathway and indirect pathway. The reason for me to discuss here, right over here, is something abnormally happening in these pathways are the reason for the movement disorder. And it is going to be those who are thinking or those who can able to understand it's not a complicating one, but considering the widespread of audience, I would like to go a little slow. That's why I'm giving a disclaimer that please be alert. So talking about the direct pathway, starting with the thalamus, we all very well know that thalamus is a relay station of the body. Normally, the thalamus would be having it. So I'll just give you a hint that whatever arrow we see in these slides in green would be an excitatory pathway. Whatever arrows we see red here would be an inhibitory pathway. And the neurotransmitters acting behind that will be for every inhibitory pathway, it is going to be a glutaminergic thing. And every excitatory is going to be a glutaminergic thing. For inhibitory, we're going to come across two. One is GABAergic, which secretes the GABA, and other one is dopaminergic, which secretes dopamine. So yes, coming back to the slide over here, thalamus would be always having a facilitatory influence by means of thalamocortical pathway over the cortex, cerebral cortex. So it tends to send excitative projection, which on the context of movement will facilitate a movement. Always facilitate a movement. So now comes, this is a normal thing, okay? This is a normal thing, whatever, even in the rest it will be happening. So whenever the cortex is planning for a volitional movement, what it will do is, before that, let me tell you the influence of globus pallidus internus and substantia nigra pars reticulatus influence on thalamus. just how we had seen thalamus is having an excitatory influence over the cortex, in the same way, globus pallidus internus is having an inhibitory effect over the thalamus. So this we can understand in the terms of a switching mechanism. Thalamus is a switch. Normally, it is kept on so that it can recruit the cortex. So whenever the globus pallidus internus is being activated, it would switch off the thalamus. So it would cut down the facilitatory influence over the cortex. So this is the basic thing. Hope you must be clear. So this is followed by, yes, this is an inhibitory projection sent to the, we call it as a pallidothalamic projections and suppresses the movement. So whenever the cortex is planning for any volitional movement, the cortex would be sending excitatory input to something called striatum. The striatum here, it refers to a combination of putamen and caudate. Fine. So it would be stimulating the striatum. The striatum in turn, it will be sending pathways to the globus pallidus via striato-pallidal pathway. Since it is red, we know it is an inhibitory one. So which secretes GABAergic neuron over here, and it switches off the globus pallidus internus. So that in turn, what will happen? It will nullify the inhibitory effect of the pallidus over the thalamus. So now what is happening here? The switch of the thalamus, which is kept off, now it is kept on because of this inhibitory. So what would be the final thing then? Much amount of facilitation or facilitatory influences going from the thalamus to the cortex will be happening. So this direct pathway, simply we can say it as a facilitatory pathway. This is governed by another important structure, which we call it as a substantia nigra pars compacta. Please don't get confused because you can able to see the substantia nigra in two of the places here.
என்னாச்சு? டைரக்ட் பார்த்து ஆரம்பிச்சிங்களா? ஆமா. அந்த இதுல இருந்து போனீங்களா செரிப்ரல் கார்டெக்ஸ் ஸ்ட்ரெயிட்டம் அது வரையிலும் வந்துச்சு. இப்பதான் அப்படியே ஸ்ட்ரக் ஆயிடுச்சு. என்னாச்சு என்னாச்சு? கேக்குது. இன்னும் வரலைங்க. உள்ளதான் இருக்கீங்க. சரி, அவ்வளவுதான். அப்படியே உங்களை அப்லோட் பண்ணி சிவா சார் கூப்பிடுறாரு. சார் சொல்லுங்க சார். முடிக்கலைங்க சார். அது நான் நடுவில் நெட் கட் ஆயிடுச்சுலாம் ரன் பண்ணிட்டு இருக்காங்க. இப்பதான் ஜனனி சார் ஒரே நிமிஷம் கட் பண்ணுங்க, நான் கூப்பிடுறேன். மேம் கன் பண்ணிட்டீங்களா? உள்ள வாங்க. இந்த மிஸ் ஜனனி எஸ்எஸ் எம்பிடி அது நீங்க தானே? ஜனனி சாயராம். ஜனனி சாயராம் அதான் கொடுத்த அப்போ நோ ப்ராப்ளம். ஓகே இருக்கு இருக்கு. நீ உள்ள ஸ்டார்ட் பண்ணலாம். சாரி பாருங்க.
Am I connected? Am I audible?
எஸ் மேம்.
Please share your screen.
So can I know that why you got disconnected? Anyone, please?
Yes, ma'am, it is connected. It is visible. You can go ahead.
Okay. Can anyone tell me where you got lost it? Like,
Ma'am, about executive inhibitory cycle.
oh, okay, fine. Thank you. Thank you. Let me just continue very quickly. So sorry for this delay. Yes. Thalamus, it's having an excitatory influence over the cortex, as we had seen. Globus pallidus is inhibiting the thalamus, already we had seen. So whenever the cortex has to produce a volitional movement, it will send a signal to excitatory signals to striatum. Striatum is nothing but caudate and putamen together is called a striatum. So the striatum is being facilitated or it is being excited. In turn, it will be sending an inhibitory, that is GABAergic fibers to the globus pallidus internus. So as a result, globus pallidus internus action will be inhibited. That is, the inhibitory signals is given to the thalamus by the globus pallidus internus will be blocked. So as a result, what will be happen? The thalamus, which has been inhibited by the pallidus already, will be out of the inhibition, or you call it as a disinhibited status of the thalamus. That in turn starts extra facilitating the cerebral cortex. So this is a complete facilitatory pathway that we can able to see. Apart from this, there is a huge contribution provided by the substantial nigra pars compacta. This is different from what you can see in other area like substantial nigra pars reticulata. So this nigra pars compacta is going to have a facilitatory input over the striatum. But please note down this point here. This connection, that is nigrostriatal, we call this fibers as nigrostriatal. Please have a or take a note on this pathway because this is going to have a very much importance in your hypokinetic disorders. So this pathway is a dopaminergic. Yes, what I'm saying is right, dopaminergic. But you might got confused that dopamine is always an inhibitory thing. But here it is given in kind of facilitatory thing. This is because of the difference in the receptors what we have in the loop. D1 receptors has been activated in cases of direct pathway, and D1 receptors always will be having a facilitatory influence over the striatum. This is the direct pathway overall, and this facilitates the movement. Please have a note on it. Saying that, we are moving to the indirect pathway, where we all know the stories of all the thalamus, cortex, and influence of it. Let's go to another interesting story that. So what would be happening to the globus pallidus externus? We have seen about the internals already. Now it is external part of pallidum. It is normally it will normally send inhibitory impulses to something called subthalamic nuclei. Remember, I told you about this as a functional component of physiotherapy. So always pallido-subthalamic pathway will be inhibitory, and as a result, you just have this in mind. So whenever now the brain is having in some other plants, it wanted to inhibit an existing movement, or it wanted to shut down any upcoming volitional movement. So in that way, what it would do is it will directly send facilitatory impulses to the striatum, and which you know that we very well know that striatum will be inhibiting the globus pallidus externus. But also you can see since the globus pallidus externus has been inhibited, the already given inhibitory influence over the subthalamic nuclei by the external will be also nullified. At the same time, cerebral cortex will be facilitating the subthalamic nuclei. So this subthalamic nuclei in turn is going to facilitate the globus pallidus internus, which we already seen in the last slide, which was inhibited by the striatum. If you have a good memory, you will be remembering. So it was inhibited by the striatum in the previous pathway. Now it had got a switch on, or it was facilitated. And we all very well know that pallidus is having an inhibitory effect over the thalamus. And since the globus pallidus internus is kept on now, it produces an inhibitory effect over the thalamus. So now the thalamus has a switch which is kept off. So all the facilitatory input from the thalamus to the cortex is going to get nullified. That is, there is a strong inhibitory influence from the thalamus to the cortex, or in other words, there is no such facilitatory input from the thalamus to the cortex. So this entire drama is ending at the place where inhibition is happening. So this pathway is also called as inhibitory pathway or indirect pathway. Again, the hero is coming in, that is substantia nigra pars compacta. Now here, it's having a receptor called D2 receptor, and D2 over the D2 receptor, this dopaminergic pathway will be having an inhibitory effect. So the striatum is being inhibited over here. So if the striatum is being inhibited, we all know that this kind of inhibition will be kept on reverteberating. That is, uncontrolled inhibition will be kept on happening. So why this, let me have a very quick glimpse on this substantia nigra pars compacta. Why are we stressing on that is, it is a dopaminergic pathway basically. If that is getting degenerated, we will be having a spectrum of disorder which is called as hypokinetic disorder. If anything is going wrong somewhere in between this pallidus externus and subthalamic nuclei, we consider that as a spectrum of hyperkinetic disorder. So dopaminergic pathway, it is going to be hypokinetic, reduced in amplitude, and something between your pallid and subthalamic pathway, it is going to be hyper, increased in volitional or unvolitional activities. So saying that, we are set and done into the movement disorder. As per the definition of William Osler, who is a Canadian physician, movement disorder is a spectrum of things, so which would be encompassed as excess of movement, either, or paucity of voluntary movement. The very important thing here is it is unrelated to the weakness or spasticity. This is very, very important. So coming to the types of movement disorder, as we have seen already, we know that hypokinetic and hyperkinetic. Hypokinetic disorders, the very well known, almost for most of the undergraduate students, maybe. If you hear about movement disorder, what comes to your mind is Parkinson's disease. Yes, that much of familiarity it has. So hypokinetic, we have Parkinson's disease. Apart from that, progressive supranuclear palsy, multiple system atrophy, dementia with Lewy body, and corticobasal degeneration. Fine. So hypokinetic disorder, so it will be an exaggerated movement, starting with chorea. So which is a kind of involuntary and unpleasant, jerky kind of movement happening in the proximal as well as distal aspect of the body. The varieties could be Huntington's chorea and Sydenham's chorea, or St. Benting's dance we used to call it as. Also in the Wilson's disease, where we have in toxicity, we can have the chorea. So followed by athetosis, which is opposite to this chorea. It is a slow, continuous and rhythmic movement happening in the distal most aspect of the extremities like hand or foot. First image, what you can see is the chorea, and second was going to be the athetosis. And hemipallismus, interestingly, only the subthalamic nuclei in your body is getting affected. We will be getting something called hemipallismus. Since just like your pyramidal pathway, subthalamic nuclei will be controlling the opposite or contralateral part of the body. So only one half. So we call it as an hemipallismus. If it is bilateral, it's going to be a pallism. It is a sudden, involuntary, very aggressive movement happening over through your entire extremity. Either it could be an upper lip or it could be a lower lip. Then followed by dystonia, it's another most common things what we get to have in clinical areas other than Parkinson's disease. Dystonia, it could be focal, segmental, multifocal, or hemi or generalized, where we'll be having a rigid contracting ability of the axial muscle will be predominating. So as I told you already, to narrow down into one particular condition, by this time you would have predicted, yes, we are going to dwell into the Parkinson's disease because of its high amount of clinical exposure and a very dynamic kind of research which is happening currently. Parkinson's disease, it was discovered by James Parkinson, and we all know that it's a progressive and neurodegenerative disease. Yes, progressive in terms, there is no kind of cure for this disease. Only we can able to halt or near halt the progression of the disease, or we can able to delay the severity of the disease. So it's a, as we have discussed, it's a loss of dopaminergic neurons, that is nigrostriatal pathway. The cardinal signs here, what we displayed here, everything is pertaining to motor. That is, the muscle will be rigid. You'll be having a tremor, especially resting tremor. You'll be having a slowness of movement. Actually, that precedes everything. Slowness starts first. Bradykinesia, at times we call it as a hypokinesia or akinesia. And as the disease stage advances, we'll be having something called postural instability. So according to the how a clinician or neurophysician will be diagnosing it as a Parkinson's disease. Yes, we have some criteria called as UK Parkinson's Disease Society Brain Bank clinical diagnostic criteria. Let me quickly show you that. diagnosis of the disease of here, we're having at least one. So that bradykinesia with at least one of the following will be having a provisional diagnosis of Parkinson's disease, like muscular rigidity or a resting tremor over the distal extremities of the upper level, lower limb, like a heading of 4 to 6 hertz, and any kind of postural instability. You can exclude all these things. I think you can just check it on later because it's extensive. Any other neurological condition overlapping along with can be excluded. So along with that, you can also have some supportive prospective like either unilateral or bilateral onset, resting tremor, progressive in nature, and definitely that is very, very important. It will be having an excellent response to the drug called levodopa. Approximately, it is told to be 70 to 100% of sustaining of the symptoms. So severe levodopa induced chorea can be occurring because levodopa, so being a dopamine agonist, all the facilitatory pathway is going to get open. So post drug, so that is we call it as an on phase. We'll discuss that later. We will be having a drug induced dyskinesias. Dyskinesia is nothing but involuntary, unpredicted, exaggerated movements. It could be a chorea or dystonia kind of thing. So these are the clinical course of 10 years or more. Yes, so this is about the criteria. So having diagnosed of Parkinson's disease, coming to the on and off period, so we will be having a first line of drugs like levodopa, syntopa that we had discussed already. We call two phases in their everyday lives of the Parkinson's patient. One would be an on phase and one would be an off phase. On is nothing but a functional state where the symptoms will be withdrawn after taking the Parkinsonian drug. That is called as an on phase. Off phase, usually we consider off phase as and worsening phase, worsening of symptom, which will be happening with or without the drug. This is the actual definition of the off period. It is not like without the drug, the symptoms is getting worsening. It is also an off period. Even with the drug, because of the dosage insufficiency or something, the patient is still having the worsening of symptoms. We call it as an off period again, or we call it as a wearing off period. So this is called as an on and off thing. Then something called therapeutic window in terms of clinical discussion about the Parkinson's disease. Therapeutic window is nothing but so now we had discussed that after having the drug, the patient will be having a reduction in the symptom. This is not same at the every stage of the patient. We will be discussing about the stages. We can have a look on it later. As the disease is progressive in nature, as the disease is getting severe more, what would happen is this on phase will get reduced. There will be more amount of drug-induced dyskinesias. So there will be a very little on phase that is called as therapeutic window. So as a researcher or as also as a therapist who dealing with a patient, we must be very, very careful that whatever assessment you do or whatever treatment you give, whether it has been given in the on phase or in the off phase. So it has to be mandatorily recorded at every point of time. So coming to the ICF model of the disease, we all know that this is the ICF model. Two of the things I didn't include it, that would be the personal factors and environmental factors. So having the health condition as Parkinsonian disease, under this body structure and function impairment, you can see this anatomical structures and physiological pathway, whatever we discussed just before, will be getting ruined as time is progressing. And clinically, what we can assess, because we're just not much worried about those neurophysiological aspects or drugs, right? So we have to concerned about something on disease progression, especially on those cardinal features what I have told. So we have a disease rating scale for that extensively. And coming to the activity limitation, so I'm prioritizing some of the limited activities that is under our scope of treatment. I'm not. There are huge varieties of non-motor symptoms. That is actually like starting from the depression, anxiousness, mood swings. The very first symptom of the Parkinsonian onset is going to be a constipation. That is an autonomic kind of thing. Followed by hyposmia. That is the patient will be decreased sensitivity to the smell. They cannot able to recognize the olfactory stimulus what they have. So all these are kind of, then there will be a cognitive diminishment, a kind of dementia we can, Parkinson's induced dementia will be there. It comes under something called non-motor symptoms. There is a study that which suggests that non-motor symptom takes place first in any kind of PD patient. And from the onset of non-motor symptoms, only after many years, you started getting the motor symptom. So then look at the gap between. The patient must be not sure that all these non-motor symptoms, they will be just neglecting it. These are the clinical negligence. So by having constipation or by having hyposmia, they would not going to directly consult a neurologist and get it diagnosed by as a Parkinsonian, because we don't have also such good criteria for very early, or we call it as a prodromal stage. We don't have that. So by the time they reaches the neurologist or the physiotherapist, the motor symptom, that is the onset of after the motor symptom, like they started feeling like a mild slowness or rigidity or whatever it is. By that time, it is suggested that almost 50% of their active striatonigral pathway or nigrostriatal pathway is been already degenerated, and there is an insufficiency of dopamine happening. So it is that years back, many years ahead, your non-motor symptom is going to set in. So here, since we are not dealing so much with that, I'm leaving off. And 2 hours scope of practice, I have included key transfers and activities of daily living communication under our activity limitation. Participation restriction. So you can find the patient would be having a major difficulty in taking part in the domestic life, going to their work, workplace environment, social engagement, and leisure activities. So there are certain set of skills. Uh, I would like to be more clear that Parkinson is an very extensive disease and it is having a huge spectrum of assessment scales. What I'm going to discuss from now is going to be a very choosy, and even though we're going to discuss about the clinimetric properties, I don't want to stress again and again, because every scale will be having, and whatever we have choosing now are going to be having a fair good amount of psychometric properties. So coming to, first of all, we encounter a patient. First, we used to stage them, right, to what stage they belong to. So for clinical staging, we are going with a scale called Cohen-Yahr scale. It was devised by Margaret Cohen and Melvin Yahr in the year way back 1967, and this is what the original scale appears to be. So we are having it in 5 points or 5 staging level here. The first stage meant for unilateral involvement alone, usually with a minimal or no functional disability. That is, the patient either can see a mild degree of tremor or mild rigidity over one side that is no way going to affect his normal functioning, or he will be just keep on doing his everyday activities. Stage 2. There is going to be an onset that whatever he experienced in one side, that's going to be just translated to the other side as well. So bilaterally, he'll be having, along with the midline involvement, midline here refers to the trunk or axial system, maybe without the impairment of the balance in the second stage. In the third, there will be a bilateral disease, and we classify this as disability cadre is coming here with a qualitative term called mild to moderate disability. And also, the previous stage, the balance was not impaired, but here you can start seeing an impairment in the postural reflexes. Physically, they might get a kind of very minimal dependency or independent completely. Stage 4, they will be severely disabling and they will be able to walk or stand unassisted. Of course, it is disabling to do their work, but not as much as they couldn't stand up or just walk or doing that. The final stage is confinement to bed. So all these symptoms will be worsened to its core, and they cannot able to do anything unassisted. So confined to one area. Here you can able to see PD, a very progressive and very slowly progressive disease. With this scale, the MDS, actually, this is a very core area. Please note down this term, Movement Disorder Society. We call it as MDS. International Parkinson Disease and Movement Disorder Society, we used to call it as. So it is a working dynamic body which tends to do all kind of active researches in these movement disorders. So they had a task force and they had a very critic review on this Cohen-Yahr stage, because being a very progressive thing, in this 5 staging, they are likely to miss out certain evolving symptoms. So that they had come up with something called modified Cohen-Yahr stage, and they had added something called 1.5 in between 1 and 2, and 2.5 in between 2 and 3. And as we discussed before, it's an intermediate course of the disease. So since it was missed out in original version, they got it done in the modified version. So coming to the Movement Disorder Society, is critic what I've told you already. It's a mixing of impairment in original Cohen-Yahr scale. They got a mixing of impairment and disability, and it was very, very non-linear when confined to the progression of the disease. And they were very, very least information given on the non-motor problems as well. So this is the existing, what currently being used by many of the researchers and also the clinical site, which is developed in the year of 1983 by Larson et al., Larson and team. I just highlight this 1.5 alone. We just see In between the course of unilateral alone and bilateral without impairing balance, you can see unilateral involvement with a mild amount of axial involvement. So this is the progression. Hope we can able to sense it as such I'm saying. There is a unilateral with axial is the interspersing thing which got missed out in the first thing. And coming to the 2.5 stage, where you can have, you got a test, we're going to discuss that in future. A mild bilateral disease, but based on the special test called pull test, they can able to recover. The recovery on pull test indicates they are having a good amount of postural reflex. So mild bilateral disease, but it is not much of affecting the postural stability. So that is recovery on pull test. Fine. So this is a very accurate and clear-cut idea about the modified cornea stage. So yes, clinical staging is done. So next thing is, according to the ICF first criteria, we are going to rate the severity of the disease, or we are going to look onto the progression of the disease by using a SOUL scale and gold standard scale for the Parkinson disease, which is called as Modified Movement Disorder Society's Unified Parkinson's Disease Rating Scale. In short, we call it as MDS version or MDS revision of UPDS. Why you call it as an MDS version or revision is just like a Kohania stage. Let me put a disclaimer again here. Most of the scales, what we're going to discuss again in this slide, are going to be having two versions, like most of, not all. They're going to have two versions like modified or revised or new, which again severely indicates that there is a high amount of research which is evolving day by day, so that the researchers don't want to miss out any component and wanted to refrain everything. Fine. So coming to the UPDRS, the original version was developed way back in 1980, and the modified version was very later, now after 20 decades, that is 2008. So now the purpose is to assess the non-motor as well as motor experiences. This is actually what was missing in the original UPDRS, where they given least importance to the non-motor thing. So now in modified MDS UPDRS, they have equal attention to the non-motor symptoms as well. So they have, it's just enough 30 minutes. Yes, it is extensive because you're going to see that the scale is so extensive, so you at least need 30. According to the patient's condition, it may extend also 30 to 45 minutes of administration time you need. And out of all of the scales, this scale is going to be a copyright of the MDS, that is Movement Disorder Society, what I stated just before. You need a critical permission from them. You can just mail them, get it, and the cost is applicable according to the countries. Like if it is in underdeveloped country, based on the margin, income margin. For certain countries, developing countries, they're doing it for free. So you can just check it on this MDS website. Coming to the rating of it, so every component of this UPDRS is going to have a 5-point scale that is starting from 0 to the 4, where we can able to see 0 is a kind of normal or without symptom. It is worsening as the stage is getting increased. The 1 is slight, 2 is mild, 3 is moderate, and 4 is going to be severe. The overall gesture of the response will be in this way, but actual remark on these points will be altering according to the field which is being tested. So we have 4 official domains, which is pertaining to the UPDRS. That is, part 1 is going to be non-motor experiences of daily living. Part 2, motor experiences of daily living. Part 3, motor examination. Part 4 is motor complications. Along with that, here comes in additional information. We would also tend to add, just now we discussed, right, modified cornea stage along with that. You're going to add the staging, and we have something also called a Schwabel-England area scale. So this entire, so officially it is 6 now, right? So this 6 part can give you a composite score of the UPDRS. Yes, so I can see that too in your mobile view, it must be highly crowding. Just for a purpose, you can just have it. We have all these 4 parts, and this much of things or components will be assessed in every subpart of the UPDRS. So without much delay, let me display the scale. So this is the original version of the scale. Copyright, I'm just saying this. MDS UPDRS, you'd be having an alongside guide along with it. Like everything would be described in a so very well way, so that the rater, that is the examiner who's applying it, and also this scale consists of 5 ways. That is, there are some sections where only the examiner could assess and mark the response, and there are some sections where it acts as a questionnaire the patient or the caregiver can mark the response. So now you can able to see this is the part 1 which is getting started here. I'm sorry, this is not the scale. Extremely sorry. Just hold on. And this is the MDS website, what you can see. So this way you can access the scale. Yes, again, you can only access, but you can't use it in your real-time application unless getting the permission. Yes, so this is the scale, original version of the scale, where you can able to see part 1, which is non-motor aspect of experiences of daily living. So let not make you tired. Let me just go on to the important aspects alone. So yes, they're being very clear. It has to be respondent that who is going to be the respondent, either the patient or the caregiver, or both are giving equal proportion. You have to mark that. Though it is subjective, it is considered to be a valid one. Starting with part 1A, that is cognitive impairment. You can just quickly see it's a question arise to the patient, and these are the responses they can give it. So next thing on hallucination and psychosis, because we can able to predict, and hallucination is one of the earliest component in the PD again. So depressed mood, so anxious mood, the apathy what they have towards the disease and their life condition. So dopamine dysregulation syndrome. So it's done with part 1A. The rest of the part 1 is going to be a question type again. On to the sleep, daytime sleepiness they will be considering. So pain and other sensations. Urinary problem coming into the autonomic thing, constipation again under autonomic thing. So lightheadedness again under autonomic thing. Fatigue they're experiencing. So coming to the second part, they are the motor aspects of the daily living. Please don't confuse this with the actual motor examination, because this is again a patient response, that is a questionnaire which has been filled by the patient, like what all they are undergoing in their everyday life on the basis of motor aspect, like how the speech has been disturbed, the saliva and drooling of saliva, how the chewing and swallowing has been disturbed, how the eating task is being perceived by them, the dressing, hygiene, handwriting, their hobbies, recreational things, so bed mobility, how the tremor would be bothering. You're not assessing the actual tremor, but on the perspective of patient, you're going to analyze here. So how they do their basically these are transfers, right? How they get in and out of bed, car, deep chair, and all. So walking balance on their perspective, freezing. So hope you must be having a good idea on freezing. It's nothing but an inability to progress forward or stepping, despite of having an intention to work. That the patient has to work really, but they got the subjective words will be like they got glued to the ground. They cannot able to clear the ground. These are the something they will be experiencing, and freezing will be often encountered whenever the patient is having kind of dual task, either cognitive dual task or motor dual task, or whenever they wanted to pass through a very stringent area, or whenever they wanted to clear an obstacle. So these are the provocative things for the freezing episodes. And freezing will be highly threatful because the freezing often leads to fall in the Parkinson's disease patient. So part 3 is our area, motor examination. And here I would like to share something that if as a research outcome, if we think that all other parts other than part 3 or just an additional thing for us, we don't really need that, we are eligible to use the part 3 of MDS UPDRS alone as a subcomponent for the outcome measure. So again, they're going to check on the on-face and off-face as I told you already. So speech. So now it is the examiner who has to observe or examine all these things and mark the exact thing what they found. Facial expression. We all know that the patients, Parkinson's disease patient will be having a masked face. Foot and knee of the lower limb. So finger tapping. They must be looking for the alternative sequential movement hand movements, dexterity, the alternatives, supination, pronation, the toe tapping, that's for agility, the leg agility, arising from chair, how well they can able to do that, and general observation of the gait, and freezing of gait by stimulating or provocating a freeze tasks, postural stability, as I told you already, by having a full test posture on observation analysis, and global spontaneity of movement, like bradykinesia, how slow they are, postural tremor of the hands, kinetic tremor of the hands. Whenever there is action tremor, we used to call it, you make them to do an action, and if the tremor is getting onset, that is called as kinetic tremor. Resting tremor, you know that on rest there will be onset of tremor, and you can see interestingly the tremor you would be finding in the extremities as well as in the central area like lip and jaw. Constancy of the resting tremor, how frequently it is happening, dyskinesia impact, and here you can able to see the covernia stage interspersing between. And part 4, motor complications we have that they are assessing in the off state first, the time spent with dyskinesia, how often in a waking day they have the dyskinesia, and functional impact of the dyskinesia, how bothersome it is, what all the activity it is preventing it from doing them. And coming to the part B, motor fluctuations, like off stage, how much of off stage, in spite of having the drug or have not having the drug, they're spending it, and functional impact of the fluctuations. Because of the fluctuation, if it is getting unpredicted, and if they are engaging in some work, is it really bothering them in that way? So complexity of the motor fluctuations again, how bothersome it is again and again. So off dystonia consists of just single last part, painful. So how for the dystonia it is it painful and how much of pain it has? So this is about the parts, and this is a score sheet. This is the one the examiner will be handling, and we can see the reflection of every component what we discussed in this page right over here. Um, just have a keen note on this part 3. So whatever thing we are that is applicable bilaterally, like rigidity, you have to examine both right and left. So all these components will be repeated twice. Rigidity on right and left, both in upper and lower lip, finger tap on the right and left, hand movements on right and left, everything. So based on this, the scoring will be proclaimed. So yes, hope you didn't get tired. Fine. So coming to the scoring pattern, we got 13, 13, 18 and 6 components as its order, and we are having composite score of 260 overall. Totally we have 50 items. I just wanted to highlight this motor examination. You will be getting 132 as an overall score, but for every response the maximum is 4. If it is 18 into 4, you will assume it has to be 72. It is not so, since we had that right and left components, right? So we have that extensive score coming here. So it is for 260. Higher the score, the more impairment they have. So coming to the interpretation, I'm just quickly going on. So based on the study, whatever is presented here right now, they are categorizing qualitatively into 3 of the categories, like mild, moderate, and severe, based on every parts they have. And coming to the psychometric property, as I told you already, being a gold standard, so this is going to be a one measure upon which other upcoming measures will be tested on. So there is no idea in point discussing on psychometric property because, of course, it's going to be a very good one. Anyway, you can have a check on it in the reference given below. It's excellent, of course. And another evidence like UPDRS on its section, coming to the analysis of overall functioning of the patient. So how well it is having inconsistency with the other outcome measures. So just an evidence for that. UPDRS just correlating with the lower limb function of the performance. Here, the researchers have concluded that it's having a better quantifying early physical functioning onset of the disease, and longitudinally it is assessing the disease progression overall, and it is assessing the efficacy of the interventions as well. Coming to the third part of the UPDRS, that is Schwab and England activities of daily history. Yes, I'm keeping an eye on the time. Let me go a little quick. So it is developed by the authors mentioned here. The purpose is to measure the daily function of the person. So it's having a range from 0% to 10%, 10% of increment. So totally we have 100% of evaluations over here. So you can able to see they are highlighting the status of dependency, how independent they were. That is higher the score. Is anything going wrong? Am I audible? Is the screen visible?
Yes, Janani. Yes, Janani, please go on.
Sorry, ma'am.
Yeah, yes, Janani, please go on.
Okay, ma'am. Thank you. Fine. So starting with, we can see the dependent status over here. So how the more the percentage we can able to see, the more independent they are. And here I will mention the descriptions of all the activities what we had just seen so far. From 0 to 100, we can able to interpret it. Again, it is having a good adequate amount of reliability and a moderate correlation that's happening with the PD patients population. So they are assessing it against the health related quality of outcome measures. So coming to, since I told you already, we are just dwelling on to the rating scale of the PD alone, but I think it would not be nice if I didn't mention it alone. So I think you would have seen the way I have entered into the MDS website, which is check on in the same way. You can able to find all these given scales specified to dyskinesia and dystonia available in the MDS website. You can have a take a look on that. So it will be covering all the rating scales, the quality of life of that, severity, everything. So these are the other scales available for other hyperkinetic disorders. So coming to the pull test, what I mentioned there, right, when we are seeing the postural stability. So it is a simple test performed by an examiner. Just let me show you the video. So this is the way the examiner has to stand supposedly behind the patient, and definitely the examiner must be having a wall behind them, and the stimulus would be by applying a forceful and intimated posterior pull. Intimated in the sense the patient must be already instructed that this way I'm going to pull you onto the shoulder, and this much of intensity it has to be. And the patient also has to be informed that by pulling that, they will be leaning back. It is okay to take 1 or 2 steps to regain their balance, but not, definitely not 1 or 2 steps. 2 steps. These are the instructions that you can able to give them. So this video can tell you that the patient is very tremulous, very trembling, that this pull evocation had made him to just have a posterior festinating pattern. So the reason you must have been logically assumed now. Why we need a wall behind? Because the examiner can get first stabilized so that they can catch the about to fall patient. So this way they can perform the pull test. So there's another alternative or another thing which is called as a push and release test. Just to contrast this, what could be the stimulus here is you just stand in the same way. The examiner must be giving a very forceful forward thrust, and the patient is asked to isometrically have a lead on the therapist. So by the time the patient is saying, I'm going to take the stimulus off, the patient have to spontaneously regain the balance, so try not to go behind. So this is called push and release test. Both the things are kind of forward go. The patient have to be proactive. They know what is going to happen, so it is a kind of assessing a postural stability as well as the motor planning and execution. 5 point again, 0 to 4. The cutoff score is like if it is more than 1, that is what we told is not more than 2 steps right. So 1 is even, it is like 3 steps of move backward. So even more 1, it is called as found to be risk of fall is higher. And in this study, they had proven that assessment of postural stability may be benefit from standardizing test delivery. That is, so far we had seen this push release test and pull test in terms of manual application. So in this study, it's an interesting one where they had applied a treadmill-based perturbation with the harness, and they can able to having an inertiometer or accelerometer, they can able to identify how much amount of displacement had been happened. So this is a kind of very good input from this. So coming to the 10-meter walk test, here we are into the domain of activity. We're going to assess the gait speed right over here in the 10-meter walk test. All that we need is not much complicated items at all. We need a hallway which is having this is a standard protocol what I'm sharing it with you. We need a 14-meter hallway, and the 14-meter has to be divided as initial 2 meter, finally the terminal 2 meter, and the central space of 10 meter have to be left. So totally it would be genuinely 14 meters, but still we call it as 10 meter. Okay. So this initial and terminal 2 meter are to assess the acceleration and deceleration phases of the gait. So what the examiner must do is Ask the patient to start from the point where the line starts. Ask them to walk in either in the slow speed or the comfortable speed or in their maximum gait speed. So they wanted to. Examiner will be having a stopwatch in their hand. As the patient crosses the first 2 meter mark, only by then the examiner has to on the stopwatch, and it will be keep counting the seconds. As the patient is passing the second meter mark, the examiner should switch the stopwatch on. So it is just the center 10-meter amount of distance only is being temporally assessed. So by means of you can able to distance by time is the simple calculation what you can able to do. You will be coming up with the outcome. Again, it is having a shown to be a very reliable, very valid tool to assess the gait speed, since the gait speed is a very important and critical criteria in intervening of PD patients, because we know the bradykinesia is the most disturbing thing, which leads to stillness of everything, including the gait. We are having a good amount of psychometric property over here. So there is an research which is saying that just we discussed, right? We need an acceleration phase, and also we'll be providing a two trials, and the composite or average score of two trials will be calculated. In this study, they had made and then concluded that no need of an accelerating distance or repeated trials if you are applying this test only in the mild Parkinson disease patient. I'm just highlighting this mild alone because it is not proven in the moderate cases. And it has been assessed as an excellent tool as a fall predicting tool as well. So you can able to see out of this research, they have proven that increasing in the 10-meter walk test speed decreased the risk of future falls by 0.76 times. So I think we can use this as also as a predictor, right? So this is a pattern of assessing it can be dealt with, which has been correlated or just correlated with the MDS first B part also. Coming to the third part of the activity, which is dynamic gait index. Let me just quickly go through because ma'am had already spent some time on that. Dynamic gait index, which was just done in the 1995 way back. And the purpose of it is to assess the individual's ability to modify the balance when walking. So this is a kind of assessing a complex walking pattern. So we just need a 12 feet or 6.1 meter pathway, and there are 8 activities which is being assessed. As told already, the activities are listed in such a way that normal surface gait without having any intervention disturbances or obstacles, and changing gait speed. As the examiner is instructing, you can now increase your speed of the gait, or examiner might be instructing, you can now decrease the speed of the gait, and the gait within horizontal head turns. Now the patient has to walk with having a horizontal head turns, just like saying no. Gait with vertical head turns, just like saying yes, okay, and gait in pivot turn. So while having a gait on its way, you may ask them to turn to a pivot which is 180 degree, 360 degree around, and stepping over the obstacle, which means that they have to literally step over or just sagittally cross the obstacle. Stepping around obstacle is something they can have a linear pathway, like either they can move to the left and step around the obstacle, or move to the right and step around the obstacle. And steps, they will be having a standard height of a step and ask them to step up and step down. So this is a scoring pattern they have, 2-point scale, 0 to 3, 0 indicating the severe impairment, and 3 indicating no kind of gait function. The total score is 0 to 24. So just quickly show the scale. So the same way, whatever we discussed, you can able to see. They have given the interpretation along with the beginning, level gait surface level walking, changing gait, horizontal turn, vertical turn, followed by every other component what we discussed. Yes. So, yes, psychometric property proven to be having an excellent correlation with the falls as well. So that's what it's been evocated. How much it is correlating with the amount of fall a PD patient is experiencing. And the minimal detectable change we can able to find in this thing is 2.9 makes a difference. So here comes an interesting analysis where in the study, so based on the DJ score especially, they have proven that even though the dopamine is symptomatically managed or given to make the symptoms better, The PD patients have shown improves gait-related mobility without improving the reactive postural responses. That is, only the mobility component is good, but not having any impact on the postural or postural stability. And that in turn might lead to a threat of increased in risk of fall. So by having the DGI and having some physiotherapeutical intervention, here you can able to see they have applied some sort of aquatic and land-based interventions. DGI can predict or can do in the amount of changes in the basis of predicting the fall risk and to improve the outcome measures used in the rehabilitation or in the physical exercises. Coming to the timed up and go test. Here I would like to take upon the dual tasking which can be added to the stuck test. Why? Because as told you already, since there is a non-motor symptoms predominantly happening in the PD patients, the cognitive based on things, so the patient will be having an increased challenge whenever the patient is asked to do when simultaneous motor come cognitive thing, which is a usual provocative factor for this freezing as well. And as ma'am told already, there is no such circumstances in our life that we will be doing only the motor or only the cognitive. Always both are hand in hand. So it is a provocative test for the freezing so far. So it is like we can perform a motor dual task. Like you make them walk. Hope you will be knowing the protocol of the timed up and go test. So they will be made to sit in a comfortable height of chair, approximately like 43 to 46 centimeter chair of height would be doing good. And they will be, as the timers get on, they're asked to get up, walk for a 3 meter, and you would be placing a cone over the third meter. Just take a pivot turn around the cone or just that cone marker, come back to the seat and get them seated. So this is timed up and go test, and the time taken for this activity will be marked. Along with this, if you have to give a motor challenge, we can have a plastic cup which is filled with water, and instruction should be don't spill away the water, and you have to do the walking order again. Cognitive dual task will be while doing this task, they might be asked to do some arithmetic calculation like just simply minusing 3 from the serial order or the descending order, or just having some minusing 2 or something according to the ability of the patient. Psychometric property is again proven to be good. So the dual tasking, so in addition to the cognitive task to the duck, enhanced identification of the fall risk, because as I have mentioned already, dual tasking cognitive with a motor task can induce a freezing, and we already know that freezing is a very important criteria which could lead to the risk of fall. So it is having a multifaceted fall risk assessment as well. So in a Parkinson and dual tasking care, so gait speed and increase in the step number had found to be provocated in the dual tasking thing, and it can also reduces the gait smoothness. By having dual tasks, you can find the gait is getting less smooth. So coming to the transfer activities. Under the activity, so far we had been discussing about the gait by means of 10-meter walk test, tug and dynamic gait index. Now we are focusing on the activity called transfer. So for that we are using an again a very well known established scale called 5-10 stand, which is being devised by the person shown in the slide. And we know the protocol of it. By having the arm around the shoulder unassistedly, they will be asked to raise up and down. For the fifth time, they're going back to the seat. You can stop the watch, which has been running already. At times, a patient, if they are doing with assistance, like if they have to push onto the arm rest, it has to be marked. Psychometric property again, it is shown to be excellent again. So coming to the evidence, like great performance and 5 times stand test will be having an important interaction with the physical activity level, which is measured by in the study in a locomotion time. So they got a very good virtual based intervention over here. So they are associating the gait performance by using 10-meter walk test, what we have just seen, along with the transferring ability, and they to be if the gait performance and sit to stand ability is good, the overall physical activity level of the will be good. Patient will be good. So coming to the modified Parkinson activity scale, it is again considered one of the important scale to predict or analyze the activity status of the Parkinson disease patient. So unfortunately, I cannot able to get the scale in the website. It is told that it is copyrighted by MDS, but I cannot find it. Anyway, they are having 14 items and 3 domains under it: chair transfer, gait, KMCH, and birth mobility. So they will be having a sort of dual tasking also in this mobility modified Parkinson activity scale, which is MPAS on its own. Total score is 56. The lesser the score, the more dependent they are. That is, the disease is very severe. The more the score, less severe it is. Again, it's shown to be having a good psychometric properties, whereas the floor effects alone was not investigated. Everything else is fine. So coming to another, this is something similar to this modified Parkinson activity scale, which is MPAS. It is called as Lindopa Parkinson Physiotherapy Assessment. So now you can able to see it was developed by Fiona Lindopa in 1998. So we are having 10 activities totally concentrating on gait and bed mobility. You can see a close correlation to this modified MPAS and LPAS. That is, both are dealing more on the gait and bed mobility. You can able to see score ranging from 0 to 30. Higher the score, better the function is. So now it is told that it's having again a good amount of psychometric property. Here comes a debate. There was a research which is saying that they are trying to compare this MPAS and LPAS on predicting the physical activity of the patient. It is totally found to be that both MPAS and LPAS is having a good amount of psychometric properties. It is reliable, both are reliable, valid, and comparatively, which is found to be better. It is not actually better. It is according to the goal of the therapist. How much of time you have, how much of accuracy you need, such a kind of. So simple differentiations are like MPAS is more comprehensive since it is more detailing looking into chair transfers and gait kinesia, which is not done in the LPAS. And MPAS is somewhere provoking the dual task so that evokes the freezing of gait, like doing a motor dual task and turning 180-degree with the cognitive dual task, which is not there in LPAS again. And MPAS, as it can be used by any of the clinical professionals, but LPAS is exclusive for the physiotherapist. Of course, it is an advantageous thing for us. And MPAS is having a lack of ceiling effect. That is, no one is under on and off, which is not be, it is just exactly opposite in the LPAS. So these are the differences. So this is to give you an oversight that yes, we can use both of these scales according to the priority. LPAS is generally told to be having, if you have a less time, and if you have a kind of qualitative assessment more than quantifying it, we can go with LPAS. On the same hand, if you need a very depth analysis, we can get into the MPAS. Approaching almost the end of the session, three more scales to discuss. Kindly stay on your patient. Freezing of gait questionnaire. So freezing again, we are bringing it under the activity. So devised by the persons shown here. It's having totally 6 items, where 4 items will be assessing the severity of the freezing of gait, 2 will be assessing the gait of it. Let me show you the scale. So it's, since it's a questionnaire, it is a subjective one. So the patient has been asked how worst, which is going to be the worst state of yours, or it's like how the gait is getting difficult while doing your daily living of activities. As I told you already, like gluing off floor, right? So how they are experiencing it while doing a complex activity like turning, or how's the longest freezing episode during the waking hour? How typically they'll be having a hesitation period, and how they'll be having a typical turning hesitation. So these are the items of the freezing gait. And I'll just show you the Lindop also, Lindop activity scale also. As we discussed, they have 2 components like gait and leg mobility. Very simple, it will be fine. So coming back to the freezing of gait questionnaire, yes, again, it's having a good amount of psychometric properties. And it is recommended by the neurology section of the American Physical Therapy Association of Parkinson's Task Force that it is a gold standard scale in assessing the freezing of gait subjectively. And because of certain recommendations again given by the task force of MDS, they have come up with another gate which is called as New Freezing of Gait Questionnaire in 2009. So it was an expanded version of it. Total score is 28. These are the 4 sections analyzing it. I just wanted to show you 2 different contradictory researches. One was done in 2009, where they are seeing that this new freezing of gait questionnaire is more reliable and having a good internal consistency. But so this was a study done in 2020. So again, by the task force of MDS, and they are suggesting that it is insufficiently reliable or responsive to detect the small effect sizes. So it is under the risk of the examiner to choose new freezing of gate question.
மேம் வாய்ஸ் கட் ஆயிடுச்சு. ஆமாம், இந்த மூமெண்ட் சட கிளினிக்கல் ப்ராக்டிஸ் அந்த ஜேர்னல் வரைக்கும் கிடச்சுன்னா இல்லாட்டி வெயிட் பண்ணுங்க மேம். ஸ்லைட்ஸ் இருக்கா? ஸ்லைட்ஸ் இருக்கா? டைம் முடிஞ்சு மேம். 4 தடவை வேண்டாம் மேம், முடிச்சிடலாம். ஓகேண்ணா, சரி, ஓகே, தேங்க்யூ. Thank you, ma'am, for your insightful, inspired presentation, ma'am. Thank you.
Thank you so much. I'm done here in the middle. Hope you would have got a good insight on that. So I were about to discuss Parkinson disease questionnaire, a long question 39 and a small version Parkinson disease questionnaire 8. I think they were my final scope of discussion. But I had one more to add, that the support diary card, which is given for the objective self-assessment of the patient's worsening of symptoms. And I just wanted to find one thing where the prodromal stage of the Parkinson disease, where the patient, as I told you already, non-motor symptom will be predominating than the motor one. There is an article which have proven that on identifying the patients in their mild to mixed form and applying the intervention, we can able to follow that secondary type of prevention model. That is, hope you know the prevention model, we have primary, secondary, tertiary. So we can apply the secondary thing where we can stop the risk or we can halt the further disability. So it is possible, very much possible in the Parkinson's patient. So with that, I would like to thank everyone who have been listening so patiently in a very often disturbing presentation. So thank you everybody for the opportunity given. Thank you so much. So if you want to ask me any doubt, you can just go ahead, or if the time is a constraint, you can post the question on the WhatsApp group. I will be promptly replying to it. It's your choice. Thank you.
That was a great session, Ms. Janani. So,
Thank you so much, ma'am.
participants, any questions? Just we have a quick discussion. We'll wait for a couple of minutes before we close. Any questions, dear participants?
Yeah, I have just one question.
Yeah, please go on quickly. Yeah.
Yes, Pratik sir.
Ma'am, can I do a descriptive study about circuit, ma'am, about neural circuit for development, ma'am, for Parkinson's disease?
Circuit for development. Of course, you cannot able to do it on the physiological aspect, but maybe having considering all these outcome measures, we can predict like which pathway would be suiting which activity. So you can activity specific, yes, correlation you can do maybe. Not exactly because you cannot intervene. No, you cannot intervene that electrophysiologically because it's something happening deep under your brain. I think you are citing on the neurophysiological loop what we discussed. Am I right?
Yeah, ma'am, I just mentioning about the Packer circuit because we don't.
Okay, Packer circuit. Yeah. So it is
because some patient
system. Yeah.
Yeah, some patients genetically varies so much about this circuit one because we train that we know in physiology Packer circuit is very important.
Exactly.
Because thalamus is a relay one.
Yeah.
Can I do?
You'll be having extensive. Definitely, with a good amount of creativity you can. But of course, as I told you already, It is just like the outcome measure what you're going to choose for that because it is highly physiological. அந்த physiological element எப்படி வந்துட்டு physically reflect ஆகுதுன்றத பார்த்து you have to tap down on an exact outcome measure. Maybe by that, to under our scope, you can do that. That's a good idea.
ஓகே இப்போ நம்ம வச்சிருக்க ஸ்கேல்ஸ் ஏதாவது ரிலேபிளா இருக்கு மேம் வீட்டுக்குன்னு ஏதாவது
But that's what you have to choose the outcome measure first of all. What you're going to choose, what you're going to check on it அப்படின்ட்டு. For example, if you just wanted to go with the kind of gait and all, you can use the scales what it
இல்ல
is.
மேம் ஆக்சுவலா ரொம்ப காமன் டாபிக் தான் மேம் ரொம்ப டீப்பா போனா அதுக்குள்ள போக முடியாது ரீலேர்னிங் வித் பேப்பர் சர்க்கியூட் அவ்வளவுதான் டாபிக்
Relearning with
ஓகேவா
concept. Okay, okay. So it would be coming under the idea of motor relearning. So you can just go and
எஸ் 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 எஸ்
yeah, motor learning பார்க்கலாம். So reproducing ability of it. Probably நம்ம டிஸ்கஸ் பண்ண ஸ்கேல்ல அந்த மாதிரி ஸ்கோப் இருக்கிற மாதிரி எனக்கு தெரியல. You might have an extensive literature review to find out the good one.
Okay,
ஓகே அது வந்து ஒரு சிலர் எக்ஸப்ட் பண்ணுவாங்களா
ஒரு சிலவங்க
எக்ஸப்ட் பண்ணுவாங்களா இதை இந்த தேரிய
anything in result is fine. Anything, everything is fine. How quickly you
Okay.
do is it
Sorry for the
matters. You have
interruption.
good methodology. That's all. Sir? Yes, sir?
Yeah.
கம்யூனிகேஷன் டீம் ஹலோ
Yeah.
So, சொல்லுங்க. Yeah.
Is there any further question apart from Pratik? So we can answer.
நோ சார் நோ சார் நோ சார் நோ
Okay. So since we are running out of the time, we would like to close. If you have any further questions, you can put in a WhatsApp group or else in the chat box. So tomorrow also we can
ஓகே
further.
மேம் ஜனனி மேம் ஒன் லாஸ்ட் ரெக்வெஸ்ட்
Yeah, please.
can I share my questions? Can you answer that, ma'am? If I have any doubt, can I put
Yeah,
questions?
Mr. Pratik, you can share your questions in the WhatsApp group also, so we can answer you also. No problem. Yeah. So you are in the WhatsApp
Okay,
group, right? Yeah.
Sorry, I'm pretty hesitant about posting questions.
Not at all. Please go ahead and
You have to come into the platform, no?
Okay.
Yeah.
Okay, ma'am. No problem. Okay, hereafter I'll do that. Thank you, Janni. Thank you. That's a nice session.
Thank you. So thank you one and all.
Thank you so much.
Thank you.
So with that, we are ending day 4 session, and tomorrow we have the last session for week 1. That is will be on quality of life assessment and as well as pain measures. So we'd like all the participants to join. So thank you, dear all. Thank you so much.
Thank you so much, ma'am.
Thank you.
Leaves
ப்ரொஃபஷனலா கேட்டாலும் பரவாயில்ல. அட்லீஸ்ட் ஒரு கொஸ்டின்ஸ்ல ப்ரொஃபஷனலா இருந்தா பரவாயில்ல.
end everyone take this. Stop streaming.